All right. Let me just get this ready. Okay, there we go. Right. So, morning, everybody. Morning, Dr. Ricardo. How are you? Shim. Dr. Ricardo joins us from Lagos. Do you guys know Dr. Ricardo?
Morning, sir.
How's it?
Yeah. Thanks.
Yeah.
Sorry, I'm traveling to Nimea now, so I'm going to maybe the next during the road is.
Yeah. Just make sure. Please pay attention to the road. Huh? Don't. you can always catch it. Leave it on the seat. Listen, and you can always catch up with the actual video later. All right? Because I am recording it, so not to worry.
No problem.
Okay. All right. No problem.
All right.
So let's just start the slideshow. Right. So far in our so far we've covered a few things. We've covered the basics of ultrasound. What is this thing doing? Sorry. There we go. What's going on here? Sorry about this. Let me just restart the whole thing. It's just not giving me a proper slideshow. Sorry about that. Okay. Yeah. So like I say, we've been doing the EFAST up till now. And so we've covered what is EFAST. We've covered the liver. We've covered the spleen. We've covered the suprapubic view. We've covered the pleural view. So today we're going to start looking at the heart. And we're going to look at the heart this week and next week. And then the week after that, we're going to look at how to tell whether our patient needs fluid or not. Okay. And then basically that's the EFAST, more or less done. But that's not the end of ultrasound. That's just the end of the EFAST. Right? So the EFAST is a 5-minute examination. So we've been spending all these weeks to learn how to do something that takes 5 minutes. Then we'll take a day. Then we'll take a day where we're going to ask one of our students. So I think Dr. Tupal wanted it. He wanted a practical demonstration. So we'll do an EFAST on somebody. All right. So we'll do it physically. Now we're not going to give them polytrauma. We're not going to beat them up. But what we're going to do is physically show how things work. All right. So today, let's go. I just want to see if this thing is actually going to work. For some reason, it's just not giving me the slideshow. And hi, Elizabeth. I'm just in a meeting at the moment. Yes. Elizabeth, I'm just in a meeting at the moment. Can you just message it to me and I'll sort it out? Okay, thanks. Bye. Okay, let's just set this because it's not allowing me to go. It's not allowing you guys to go. I don't know why. Just close this up. See what happens. Sorry about that. Okay, so the problem is more with the PowerPoint rather than with you, with anything else. Sorry. Just get the slideshow started and then I can. It's just not giving me a slideshow. That's why. Okay, my apologies. Just a little bit of a technical glitch on this side. Is it just not allowing me? Okay. Damn it. Okay, let's not run it as a slideshow then. Just run it as a normal thing. Sorry about that. Sorry. No, I think it's not you guys' audio. It's actually my side. Sorry, I'm actually just trying to get the whole thing up. I'm just not sure why it's not working at the moment. Okay. I just want to see. It's not projecting, but at least it's allowing me to get in. Ah, there we go. Okay. The only thing is all right. So to those guys who are following on Zoom, my only apology is that you all will see it in presenter view and not a full screen. There's not much that I can do about that. It seems that that's all that it's allowing me to do. I presenter view. Let's try. Nope, not working. I had it and now it's gone. Oh shit. Okay, can I try it one more time? Do you mind? Okay, thanks. Sorry about that. My apologies. Show presenter view. Let's share screen. Sorry about that. I'm also learning some of these things, so let's try sharing that. And let's try slideshow from the beginning. There we go. All right. So unfortunately, there's not much that I can do because it's only allowing me to share it with you guys in presenter view. For those who are watching on Zoom, for those of you who are here, you'll be able to see the whole thing. All right. All right. So let's start. So as I was saying, we are now looking at what we call the subxiphoid window. All right. So the subxiphoid window is essentially that we're looking at the heart from the bottom. Okay. Now, the hardest part for most people is the orientation. Okay. So when we have the subxiphoid window, and it can sometimes be a little bit difficult to get, this is where we place our probe. Okay. So probe is lying on this patient's abdomen. It's pushed in a little bit. And I'm going to show you a video exactly on how you do it. But essentially, we're trying to look at the heart from this point of view. Okay. So what you would normally see, if you get it correct, is that you would see the stomach, you would see the liver, then you would see the right ventricle, right ventricle, left ventricle, right atrium, and left atrium on that side, right? But I've got a lot more examples of it. I just wanted to show you more or less what it looks like, right? So the question you may ask is, why are you seeing this as it is? Look at where our probe is placed. So what's lying over here in this area? Liver, exactly. So that's why the liver is closest to the probe, all right? Then the liver is going further through into the chest. Which chamber lies closer to the front of the chest? The right chambers. Okay, the right ventricle lies closer. That's why you're seeing the right chamber first. And the left ventricle is more posterior. So that's why you're seeing the left chamber at the back, all right? Now, there's a few things with this. Number one, if your patient has severe abdominal pain, very difficult because you often have to push the probe down and try and angle it and things like that. So it can be a bit difficult. And if you've got a bit of a, I wouldn't say posterior heart, but let's say a rotated heart, it can be a bit difficult. Right? But at least it's a good place to start. So what I'm going to show you guys now is we're just going to watch a little video on how you actually place this probe. Okay.
A phased array transducer with an abdomen exam type is used to perform the subxiphoid or subcostal view of the heart in the fast exam. Place the transducer in the subxiphoid position with the orientation marker to the patient's right side at a 9 o'clock position. This view uses the liver as an acoustic window to visualize the 4 chambers of the heart. Aim the transducer slightly toward the left shoulder at a 15-degree angle to the chest wall. In some cases, the transducer is almost flat to the abdominal wall, so the ultrasound beam is directed toward the left chest cavity. A considerable amount of ultrasound gel and downward pressure may be needed to maintain contact of the transducer face with the abdominal wall. Increase scanning depth to visualize all chambers of the heart. The first structure seen closest to the transducer is the liver. The right side of the heart will appear closer to the transducer than the left side of the heart on the ultrasound image. The myocardium will appear gray, and the blood-filled chambers will appear hypoechoic. The bright white pericardium is seen surrounding the heart adjacent to the gray myocardium. Evaluate the function of all chambers. Compare the size of the right and left ventricular cavities. Note any wall motion abnormality and the presence or absence of pericardial effusion.
So when we're doing this assessment, there are two things that we are looking for. Number one, we are looking for the motion of the heart, but very importantly, we're also looking for a pericardial effusion, right? So the reasons for pericardial effusion are many, but specifically in an EFAST, where it's related to trauma. So is there trauma to that pericardium? Has there been a puncture to that pericardium? Now, this doesn't mean polytrauma patients. We're talking about stab patients, you know, rib fracture patients, things like that. We want to know if anything has gone through and poked that heart. Okay, but it still forms part of the EFAST exam, right? So everybody understand now how you get the probing, right? So for example, if you have somebody like me, nice big tummy, and you try and push down, you may not be able to get far enough down to actually have a look at that, right? Whereas take our young lady over here, Shane. With Shane, the probe might still be 2 meters away from her, and you can probably see her. She's so thin, right? So you have to understand that as well. Okay, now in order to counteract that, next week we're going to look at another view that you can look at, right? In case you are struggling from there. But these are the things that you have to consider. Okay. Also, for some people, the heart may be a bit more anteriorly, depending on diaphragmatic conditions and things like that. Then it can be a bit harder to visualize. And it depends on your machine as well. So like we're quite lucky. We've got a relatively new machine. So today, if you guys have a chance, try and put it on somebody and have a look. And you'll be able to see quite a bit. Okay. All right. So just to give you more of an illustrated view, this is where your probe is. Okay. And this is what you are seeing. All right. So the right ventricle there at the front, which we expect to be a bit smaller and a bit more thin-walled. Then we come to the left ventricle, which is supposed to be thicker and a little bit larger. That's normally how it is. And then the right atrium and the left atrium. We don't really see much more than that, all right? You do see your valves as well, but this is not the main view in which to test your valves, but you can see your valves as well, all right? I'll just give you one more, just so that you can see. So this is now a moving picture. How do you pronounce it? GIF or GIF? Everybody has different ways. Shan, you're young, you know, GIF. GIF, all right. So this is a GIF of what that should look like. Okay, so you've got right ventricle, right? And look at the shape of your right ventricle, right? It's a triangular shape on this, okay. You look at your left ventricle, it's more of an ovoid, okay. Then you look at your right atrium, much larger than your left atrium in these views, okay. That's good, all right. So we're going to watch another video that's going to show us exactly what we should be looking for when we do this, all right? It's not very long, but long enough just to.
Is going to be that backward view indicated towards the patient's right, shooting through the liver to the heart. And what we're looking for is a view through the liver to the heart, both right and left side structures. And we're looking for the presence of cardiac activity and the presence or absence of pericardial fluid. So we're going to see the liver, we're going to see the diaphragm, the right sided chambers, and the left sided chambers. We'll also have some view of lung and lung artifact in this view. And this is what your view is going to look like. You're going to see the liver and you're going to see the heart, treating from an inferior towards superior portion. And we're going to look for cardiac activity and presence or absence of pericardial fluid. There's another view where we're using a curved array, treating through the liver to the heart. And you can see there's a little bit more gas artifact here, both from the stomach and from the lung. And what we're looking at is the liver, the stomach, with air artifact from an air-filled stomach, the diaphragm, right-sided chambers, and the left-sided chambers. We also see some mirroring artifact because of aerated lung. And here's a view where we can see a pericardial effusion with the anechoic layer separating the heart and the pericardium. The pericardium is abutting the diaphragm as one continuous line. Here we can see another sample where we have pericardial fluid. Here we can see another example where we have pericardial fluid and a pericardial effusion. We also see the presence of pericardial clot within that pericardial space. Here we see pericardial effusion. However, this is concerning because pericardial effusion is actually impacting cardiac function. We see that the right-sided structures, both the right atrium and the right ventricle, are not contracting normally. Instead, they have this undulating or collapsing effect, and that's because of the pericardial fluid inducing a tamponade physiology. Here we see lack of cardiac activity, where we can clearly see the heart, and there's no contraction of the heart. So So once again, we're looking at our subxiphoid view, and we're shooting through the liver to the heart. If you have a large amount of stomach gaps, you see where the probe is located. You can slide towards the patient's right to try and hinge through the liver and avoid the stomach bubble. However,
so we're going to go through a few examples of what things look like. So just for a second, we're going to stop and we're going to ask ourselves, why are we worried about a pericardial effusion? What's the problem with the pericardial effusion? I mean, people live with pleural effusions for weeks and then come to us and they just have a bit of shortness of breath. Why are we worried about a pericardial effusion? Any idea? What is a pericardial effusion doing to the heart? Very good, very good. All right. So whether it be a stab heart, whether it be a direct trauma to the heart, rupture of an aneurysm in the heart, whatever it may be, all right? So you've got this heart that's sitting over there, surrounded by this pericardium. How many of you guys did, like, I know some of you don't, they no longer do like proper anatomy where you cut up cadavers, but did any of you ever do it? Did you do cadaver cutting? Stuart, did you do cadaver cutting? Do you remember what the pericardium is like? All right. You know that bag, when we buy rice, you know, we buy rice in that sort of like that knitted bag. That's what the pericardium is like. It's like this tough layer. It's not actually a very spongy layer. All right. It's quite tough. It's got a bit of stretch. Yes, yes. You know, so it's quite a tight thing that sits around the heart. Okay. So what happens is now you have this quite tight thing with a little bit of stretch on it that's now filling up. All right. So it can't stretch that much. So where's all that pressure directed? That pressure is directed inward towards the heart. Okay. Now, how does the heart work? The big question, but I'm going to put it in a simple way. Here you've got your heart. Your heart needs to contract. But for your heart to contract, it must first be able to expand. All right. Everybody remember Starling's law? Don't worry, everybody's faces go like, somebody else should know this, right? So Starling's law deals with contractility, all right, of the heart. So up to a point, all right, for you to have good contraction, you must have good expansion. Basically, you stretch your muscle fibers, all right, your myocardial fibers, and they will then bounce back, all right? And that's up to a certain point. So in other words, stretch them a little bit, they can only push a little bit. Stretch them a bit more, they can push a bit more. Stretch them past a certain point and they can no longer contract as well. So good thing to go and check. But if our heart is getting constricted, what's happening to those myocardial fibers, that actin and myosin? They're not getting an opportunity to expand because you're not getting enough filling. Okay, so there's not enough filling, so there's not enough pushing out. Okay, so you get this little bit of filling, this little bit pushing out. That goes round in that circle throughout your whole body. And when it comes back, how much is going to fill the next time? Even less. So you're going to get less going through. So how much is going to go the next cardiac cycle? Even less. So you've got this downward death spiral. Your heart is pumping out less and less. So there's less and less coming in. So there's less to force it to open up. This is why a pericardial effusion is such a problem. So how do you relieve a pericardial effusion? You have to remove the fluid, all right, which we'll get to now. This is why it's such an emergency. A person with a pleural effusion can sit for quite some time because you've still got lung on the other side. But a pericardial effusion can very quickly devolve. All right, that's the thing. The other thing that happens as well is when we want to take, now we're only talking about one ventricle. When you're talking about the right ventricle, the way the right ventricle works is every time you breathe, you do that. How does air go in? The diaphragm moves down. It creates negative pressure in the thorax. When it creates that negative pressure, it's like a vacuum for the inferior vena cava. So it sucks in all of that, right? Now you've got this whole amount of pressure that's happening over there. That no matter how much of pressure you apply to the inferior vena cava, it cannot suck blood into that right ventricle. So you keep on having both of these ventricles having less and less and less and less blood. And eventually, once there's too little blood, the patient demises. That's it, okay? Because remember, the heart is dependent on itself for its own blood supply. So the less it's pumping out, the less it's getting to itself. So you see, it's literally a death spiral. You just keep on going down, 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 down until you die. Okay, so this is why we worry about this. Okay, so now what we're going to do is we're going to try a few examples and let's just see. So let's have a look. So here we have the subxiphoid view. So the first and most important thing to note is what can we see? Now, the reason why I'm showing you some of these is because you must be able to identify that you will never always get a perfect view. Sometimes you'll get bad views, sometimes you'll get good views, but you should still be able to know what you are looking at, all right? So for example, here we've got the liver, all right? What ventricle is this? What do we expect to see there? The right ventricle, all right? And there we see the left ventricle, all right? So we can't see the atriums too well over here. What's this that we are noticing over here? Very good, fluid. And what fluid would it be? A pericardial effusion, all right? Let's look at some other things that we notice, all right? What do you notice about this left heart? Even compare it to this heart, what do you notice? Its contractility is? Yeah, it's not contracting that well. I mean, it is contracting, but it doesn't even look like the whole wall is contracting, even if you compare it to the right ventricle. So this is another thing that we look at, okay? So possible causes of that, ischemia, direct damage from trauma, all of these things can cause a decrease in contractility, okay? Now let's look at this particular picture. Again, what do we see here? Liver, all right. Which ventricle is that? Right ventricle. Which one is this? Left ventricle, very good. And that's the right atrium, and that's the left atrium. What do you notice over here about this? Compression, very good. Can you see it's doing this when it's contracting? The reason for that is the amount of pressure that's being placed by that pericardial fluid is actually causing cardiac tamponade. And cardiac tamponade is exactly what we described just now. There's an inability for it to fill. So as it's trying to push out, it's struggling as well. Okay, we look at the left ventricle over here. The first thing we notice is very thick. All right, so this is actually hypertrophic cardiomyopathy on this side, but that may have been pre-existing. All right, we're not saying that's what's there. The thing is, your ventricles are not supposed to be hitting against one another. All right, there's always, if you guys have ever seen an echo report, it always talks about ejection fraction. All right, so your ejection fraction is meant to be above 70%. This is 100%. That means it's trying to push up everything. It's just pushing and pushing and pushing. So this tells you how much the heart is struggling. Okay, so the only way to stop it is to get all of that out, which we'll get to just now. We're going to cover that in a little while. Okay, all right, but at least you can recognize it. All right, so even if you don't know what to do, but at least you can recognize it and you can call somebody and say, listen, this is what is happening. So let's see what can we do about it. Let's go to the next one. All right, so let's have a look at another one. So what do we see here again? Liver, all right, oops, sorry, right ventricle, left ventricle, right atrium, left atrium. And what do we see around it? All right, small amount of fluid, large amount of fluid. Very large amount of fluid. And look at this right ventricle, what's happening to it again? It's compressed completely. It can barely get anything out. Okay, so that's the important thing to know. So that's one of them. And if we look at this one, all right, we see a similar picture again. Right? Liver, right ventricle, left ventricle, right atrium, left atrium, large amount of fluid, and collapse. See that pattern like that? You can see it on both of them. The reason why I'm showing you so many examples of this is because if you just see a normal pericardial effusion, all very well and good. That's fine. You see a pericardial effusion, we know it's there, we know we have to do something about it. But if you see something like this, it means your patient's going to die very soon. So you can't take a break. If you don't know what to do, you have to get somebody and say, listen, this is what we need to do. Be it a radiologist, be it a surgeon, be whoever it is, somebody has to get in there and remove that fluid, all right? Now, in this case, you would call me, all right? If I'm not there, you'd call Dr. Tonko, because she obviously knows what to do. You can see it now. No, I'm just joking. Yeah, she's also looking just as worried, all right? But what I'm saying is you would call, for example, the surgeon or the physician, and you would say, listen, this is the problem. We've got a patient with right ventricular collapse, secondary to a pericardial effusion. And remember, even though we're talking about trauma, this can be from anything. All right, pericardial effusions can be from anything. You can get them from CCF, you can get them from TB, you can get them from bacterial infections. There's a lot of reasons for you to get effusions. So the important thing is that you can recognize it. All right, what do you think the cardinal signs besides I mean, what would be the clinical signs of this? Do you think? What would you see physically on the patient? All right, first of all, what do you expect the blood pressure to be on this patient? Low, very low BP, all right. All that blood that's inside over here, or all that blood that can't enter, where's it gonna go? It can't go into the heart. So that means it needs to stay in the veins. So which are the veins that you're going to see? Neck veins. Your neck veins are going to start to swell up. Yeah, they're going to distend quite a bit because there's nowhere for the blood to go. So it has to get stuck there. And if you were to listen to this heart, there's so much of fluid over here. How do you think your heart sounds will sound? Muffled, very good. All right, so muffled is a nice way of saying soft. All right, basically soft heart sounds. You have low BP and you have distended neck veins. So even before you were to put a probe, you would already have an idea that this is possibly something that yeah, okay. So remember that. So let's have a look at one more. All right. So here we can see complete diastolic right ventricular collapse. All right, because of this. We identify the liver, we identify the right ventricle, the left ventricle, right atrium, left atrium. In this case, you can see that undulation is quite bad. Look at how it's undulating, right? Because it's struggling against that fluid. There's hardly any output, all right? Compare this to this left ventricle where at least there's some contraction. There's something going on, right? And on this side, there's almost no contraction, right? So this is a patient on the verge of crashing. So the question is,
yeah.
Not sure, but I think that's from somebody's phone, sorry. So the question is, what do you do? And the answer is pericardiocentesis, all right? So has anybody ever done a pericardiocentesis? Sounds scary, isn't it? Right. To stick a needle in somebody's heart, I mean, it's not fun. What if you end up in one of the ventricles? What if you make it worse? It can happen, that's for sure. And in the old days, yes, it was a very difficult procedure because there were specific ways you had to do it. There were a lot of complications associated with it. And nowadays, if you have access to an ultrasound, it's actually not that bad. So let me show you how we do it, all right? We're on to our last slide, all right? So we're gonna watch how they do pericardiocentesis.
This is an example of a small pericardial lesion. In this particular lesion, there's no evidence of pericardial tamponade, which is, of course, the thing we are most concerned about, and the reason for performing pericardiocentesis. Pericardial tamponade can be visualized on ultrasound, but it's not 100% sensitive. So if the patient has a good clinical presentation and the presence of effusion, you really have to worry about tamponade until proven otherwise. When we think about pericardial tamponade with ultrasound, there's three things that we look for. The first and probably the most important is right ventricular collapse. This is an example of right ventricular collapse from a pericardial effusion called a tamponade. Here we see the free wall of the right ventricle is collapsing during diastole. The next thing we look for is the presence of a collapsed LV. So we think that if the patient has a reduction in forward flow because of collapsing the right ventricle, the LVs therefore not filling. This makes the LV hyperdynamic, meaning that the walls touch during systole. So this patient, for example, has an ejection fraction of approximately 100% because the LV walls are touching during systole. That's because the LV is not filling appropriately because of the lack of forward flow coming from the right side of the heart. The last thing we're looking for is a dilated IVC. If someone doesn't have appropriate forward flow because of lack of filling to the right side of the heart, we expect the blood to back up.
This we'll get to in the next few weeks, the IVC.
So look at this, we're looking at a subcostal window. This is a subcostal long axis window. You see the effusion here. Here we see the liver, and the IVC is nice, fat, dilated, and not collapsed in all respiratory radiation, telling me that there is a significant reduction in forward flow. To perform a pericardiocentesis with ultrasound, you're going to need a couple of things. The first and most important is obviously the ultrasound machine. And we can use either the curvilinear abdominal probe if we're performing it subcostal.
Yeah, oh, I think there's some feedback from some people's microphones. If people could just mute their mics. Thanks.
Technique. Or we can use the thoracic probe or the cardiac probe
apical technique or with the subcostal technique. Of course, you'll also want a pericardiocentesis tray. Now, you don't have to have one of these. If you're not placing a catheter, you can simply use a spinal needle and a large syringe. However, if you do want to place a catheter, I recommend you keep a pericardiocentesis tray in your emergency department. There's two particular windows that we use when we perform a pericardiocentesis under ultrasound guidance. That's the subcostal window, which is the more classic window performed usually without ultrasound guidance, and then the apical window, which has gained a good bit of popularity since the use of ultrasound for guiding this procedure. Some people also use a peristernal technique going in the third or fourth intercostal space. However, I prefer not to use this due to the location of the left anterior descending artery. The concept of lacerating that artery just sort of scares me. This is an example of performing an ultrasound-guided pericardiocentesis from the subcostal window. The steps that we mentioned here are pretty much the same steps that you would use with the apical window, the only difference being the orientation of the ultrasound probe. For this particular example, we're using a curvilinear abdominal probe. However, you could also use the thoracic or face array probe for this particular image. Here we see we're looking at a heart with a fairly significant diastolic collapse of the right ventricle and a fairly large effusion. We're going to be coming through the liver here, and we're actually visualizing the pericardium through the liver here. I'm going to insert the needle just lateral to the probe to the patient's right side. That way I'll be going through the liver and towards the patient's pericardial sac.
You can see the sorry.
As I insert the needle and draw back, I'll get a flash of blood into the syringe. Once I've seen this blood, I'm going to confirm that it appears my needle tip is in my pericardium. After I do that, I'll take the syringe off and I'll place a wire through the needle into the pericardial sac. Again, confirming that the wire is in the pericardial sac and not the ventricle. I'll use ultrasound for this confirmation. Then I'll slide a dilator over the wire and finally pass a catheter over the wire and remove the wire. At this point, I can place the wire to down drain to drain the pericardial effusion. Here's an example of a real-time performed pericardial effusion. Here we're using the phase array probe from a subcostal window, and you can see the needle coming in just about right here. We see we pop through the pericardium, and once we pop through the pericardium, we're going to start advancing our wire down. You can see the wire pushing down on the right ventricular free wall here as it goes into the pericardial sac. After the wire, we'll of course push the dilator over the wire. Here we see the dilator coming in, and then finally the catheter will be placed over the wire into the pericardial sac. Once the catheter is in place and it's hooked up to down drain, you can actually see the pericardial effusion diminish in size. And here we can see that pericardial effusion getting much smaller.
Okay,
In addition to the subcostal window, you can also use the apical four-chamber window. For this particular window, I'll again place the needle just lateral to the probe. However, this time I'm going to come from a medial orientation directed towards the apex of the heart. I'll again be able to see virtually the same thing that we saw with the last image. However, we'll of course use the phase array probe in this instance because it's much easier to visualize through the rib spaces with the phase array probe rather than with the curvilinear. A few tips and tricks. So agitated saline is a great technique for making sure that you're actually in the pericardial sac as opposed to placing the needle or the wire into a ventricle. Here's an example of injecting agitated saline into the pericardium once you have the needle in what you believe is the pericardium. You can see how the agitated saline lights up and is extremely hyperechoic in the pericardial sac here. If we were inside a ventricle, say the left ventricle, for example, we would see the left ventricle light up as opposed to remaining dark here. Agitated saline can be a great way to confirm you're in the right location, especially if you're trying to tap a small pericardial effusion or if you're just not very comfortable with placing a large dilator into a ventricle. Needle in plane technique. Some people talk about using the needle out of plane technique, which would mean going with the needle through the center of the probe. However, I prefer having the needle come in laterally so that we have the needle in plane and in view the entire time. This allows us to see the needle tip and really know where it is in space. So I'll have the needle come in just lateral to the probe, and then that way I know where to expect it on my screen. I would expect the needle coming in just here laterally going towards the pericardial sac. Again, I'm going to have the needle actually come in right next to the probe marker. That way I know to expect the needle coming from the probe marker as seen here. Go where the fluid is. It's important to remember that with pericardiocentesis, there is a margin for error as possible. So wherever the pericardial effusion is the thickest is probably where you should go with your needle. If that happens to be peristernal, even though Malin said don't do it on his little podcast, go for it. Whatever you think, whatever you're most comfortable with. So apical, subcostal, peristernal, wherever that effusion is the largest, is probably going to give you the best chance of success without taking out a ventricle and placing a catheter in someone's aorta.
Okay, I think that's the end of it. Now, as you can see, it's a procedure that has the potential to have a lot of complications, right? But you never know. You may end up as an intern working in a hospital for the students, for example, where really nobody cares. They just put you in the emergency department, everybody goes to sleep, but if the patient dies, it's your fault. You know what I mean? Or you end up as a community service doctor, an MO in Patafontaine, where there's nobody, you know? You basically have to cover everything. But you're lucky enough to have a little ultrasound or you suspect this. So it's at least a technique that you can say, okay, I remember something. You go back on your WhatsApp and you quickly have a look and you watch this video. But for those of us who have put in CVPs, the insertion of a pericardiocentesis pack and the insertion of a CVP is essentially the same thing. You're following an ultrasound, you're getting into a space where there's fluid, you're passing a guide wire, you're passing a dilator, and then you are passing another port over that. That's exactly what we do when we're putting in a CVP. Just that when you put a CVP, you put it femoral, you put it subclavian, or you put it in ternojugular. Why I'm saying that is because you may work like in a place like Madadeni that doesn't have a pericardiocentesis pack. There is nothing like that. It doesn't exist. So use a CVP pack and you can get it in. Got it? Understand? It uses the same principle. The only difference is that the attachments that go onto the port are different. Okay, so hopefully you guys never have to do this. But if you do have to do it, then we'll show you how to do it physically. It's just a nice skill to know. It's a nice skill to be able to have at the back of your mind and know that it needs to be done. And it can be done blind as well. So if you are going to do it blind, then you actually just hook up your patient to a 3-lead ECG. And as you advance your needle, if your needle hits the ventricle, you get a damage pattern, which means you get a sudden erratic view on the ECG. But it doesn't tell you how far in you've gone. So you don't know if you've gone through the ventricle, touched the ventricle, whatever it is. So that's why it's a bit more difficult to do, and it's much better to do under ultrasound guidance. Okay, so I just want to know if there's any questions at the moment, because from my side, there isn't much else, all right? You know, if you guys want to know anything that seemed a bit confusing, we can always take it further from here. And just sorry to the guys on Zoom, I don't know why it's not putting up a full screen, not allowing me to use the, what you call it, full screen for Zoom. But any questions, anything you want to know? Yeah. Yeah.
Then you remove the blood.
Okay. So
sometimes the wound can seal, or you still need a thoracic.
I must be honest, in stab hearts, most of the time the blood congeals, clots, long before you can actually get a needle in. So when it comes to a stab heart, you can diagnose it, but you can't necessarily do much about it in an emergency department. Those people need to go for a thoracotomy. Okay, yeah, for a thoracotomy. So a pericardial effusion in the face of what you call it a stab heart, if you see that the fluid is still, or the blood is still liquidy, you can still try. But in most of the cases, that means it has to be quite acute. You're talking about within like 15 minutes. Patient is stabbed, comes directly to hospital, you pick it up, you can pass a needle, you can try and pull out some of that blood. More commonly, what we get is patient with medical conditions, you know, or like, for example, how can I explain? Very minor leak with a very minor amount of fluid that's coming out. And because of the motion of the heart, it's unable to clot as quickly as it can. But the majority of the time, I must be honest, a big stab heart, you won't be able to. You know, once we've tried it once or twice, but because it clots up so quickly, it's very difficult to actually pull out through your needle. So you don't even know whether you're in the space or not, because it's just clot that's sitting there, you know. But what will give you an idea of what it is, let me just get it up over here where they did have the clot. Just want to see that one that had the clot. Or was it on the video? I think it might have been on the video. But anyway, so clot looks a bit more hypoechoic. Blood is anechoic, or fluid is anechoic, which means completely dark. Clot is hypo, which means slightly lighter gray. So once you see slightly lighter gray, there's not much that you can do. That's the thing, you know.
Similar to
Yes, hemotherapy. Yeah, you could aspirate. Yeah, definitely. No, it can. There's no doubt. And in trauma, I'm just saying in a stab heart, very often it doesn't seem to work that way. I don't know why. But with lung puncture, I mean, with the rib punctures, things like that, we do see it and you can take it out. Yeah. So it's the time to presentation as well that makes a difference, you know. So, you know, what I'm saying is if you see it and if your patient is collapsing, it's something that you should know how to do. If your patient is not collapsing, don't rush to do anything because you may cause more harm than good. Okay, that's what I'm trying to say. So, but it's a good question. It's a good question, that's for sure. It's something that you need to know about, you know. I'm not sure if anybody else has any questions or anybody on the Zoom as well. Did I not do this? I should have. Okay. All right. So if everybody is okay with that, then what we're going to do next week, we're going to look at the parasternal long view. All right. Long axis view, which is another view of the heart. So we'll cover that next week because sometimes, like I say, you can't see this view at all. And yeah, hopefully then you guys will be mini echo technicians and be able to. But as I always say every week, you must be able to put your probes on patients for whatever reason. Just make excuses and just put your probe on a patient, okay? And hopefully you'll get the hang of it and hopefully you will learn what to do. So yeah, I don't know if there's any questions. I don't see anything, no questions from the guys on Zoom. So if it's okay with you all, then we'll end the meeting here. And yeah, I'll put up the invite for the next meeting and then we'll see from there. Okay. All right. Thanks, guys. All right. I'll be there in a few minutes. Okay.
Thank you so much.
Everybody on Zoom. Bye.
Bye.
Thanks for joining.